Hello, everyone. My name is Asim Khwaja. I'm the Director for the Center for International Development at Harvard Kennedy School. On behalf of CID and the Institute of Politics, I want to welcome you all to this virtual JFK Jr. forum on catalyzing global leadership to contain the impact of COVID-19 with Peter Sands and Atul Gawande. Look, if there's one Zoom seminar you should be listening to probably now, it is this one. We are really in one of the toughest and trying times that we are facing in the world. These are serious times. These are times with great intellectual challenges that we all face. And the challenges are not just in how we deal with COVID, but also in dealing with COVID, what else are we ignoring? What are the other concerns, both in health, but otherwise in the economy that we may be facing with? This is a challenge we must all face, but it's a challenge which is a very comprehensive challenge in health, in healthcare systems. And it's a challenge where every country, and especially those with limited resources, the emerging economies, the developing economies, these have profound long-term consequences for all of us. We hope that in coming together for these conversations, as in today's events, we can spur and move the needle in terms of us addressing really pressing problems that help build a thriving world for all of us. I'm terribly excited to have both of our speakers today. They've been incredibly generous with their time at a time when time is incredibly precious. Atul Gawande needs no introduction. He's one of our faculty at the Harvard Med School and the Chan School of Public Health. He is one of the most remarkable people I know of who basically can balance both being a superb academic, a superb clinician, but also someone who can really inspire the public, the wider audience, engage with them, inspire them to think. Atul has agreed to moderate this discussion, so I'm incredibly grateful for Atul for agreeing to do this. Today's main speaker is Peter Sands. Peter, I should start by saying Peter has been spending time at the Kennedy School, so I will start with his affiliation that is closest to us. But Peter is the executive director of the Global Fund, which is a partnership that mobilizes and invests more than $4 billion a year to support health programs run by local experts in more than 100 countries. This is a remarkable achievement. And we should already thank Peter for playing this role, which literally saves millions and millions of lives. He is a former chief executive at Standard Charter and has been a fellow with us, like I said, since 2015. I'm really looking forward to discussion, so I won't stand in your way anymore. And with this, let me hand over to Atul. Atul.
Well, thank you, Asim. Thank you to the Kennedy School, and thank you above all to Peter for joining us. Your bio, I want to start with your bio and understanding more about the Global Fund, and before we get into kind of today's issues around the coronavirus. You were a banker. You were the former CEO of Standard Chartered, which the Google tells me is one of the top 50 largest banks in the world. And so after that, you said, okay, what do I do? Well, I should come to the Kennedy School. And you came as a fellow. And then from there, you took over the leadership in 2018 of the Global Fund to fight AIDS, tuberculosis, and malaria. You are increasingly engaged in the COVID fight. We're going to get to that. But I've long been fascinated by the Global Fund and a little vague about how it does its work. It's really one of the most remarkable investments in the world. You saved 38 million lives since its founding, 9 million in 2019 alone. And the first question I want to ask before we get into COVID is, how do you know the Global Fund saved all those lives, and what did you do? How did you go about doing it?
Right. Well, it's a very good question, and it's one of the first questions that I asked when I came into the Global Fund, because actually I'm not a clinician, I'm not a scientist. They weren't used to having somebody like me who has run a large international bank, whose training is much more on the sort of economics and finance side of things. But I was intrigued by these numbers, and I was like, well, so, how do we make this calculation? And actually, we don't make that calculation. It's done by, largely done by a modeling group at Imperial, but also by others. And what they have done is they've basically projected where they think the three biggest infectious diseases prior to COVID, HIV, TB, and malaria, would have gone. Not saying without any intervention, but taking account of the specific interventions that the Global Fund has put in place. The biggest single thing is simply HIV was the last big pandemic to hit humanity. It's killed about 35 million people, but there are 20 million people alive today on antiretroviral treatment who wouldn't be here. And in large part, that's due to the Global Fund. You can make similar calculations around malaria and around TB, but each one of them is based on that kind of analysis, which you can always challenge the underlying assumptions.
What are you doing? Sorry to interrupt. And let's dive a little deeper. What are you specifically doing that makes HIV treatment much more widely available? What's the model to enable the financing and the difference that you're kind of designed to make?
Well, when the Global Fund was created in 2002, the treatment cost for putting somebody on antiretroviral treatment for a year was about $10,000 a person. Our treatment cost for that now is about $75 a person. And so we're doing it at massive scale, consolidated procurement, and that I think is the difference between the Global Fund and many of these kinds of interventions, is that we're doing this at big scale, and we're not interested in just saving some lives and helping people. We're interested in actually trying to solve the problem. So my objective is to get rid of HIV. My objective is to get rid of TB and to get rid of malaria. It's not just to make them somewhat less deadly.
So the critical thing that you're doing is you are enabling massive purchase that which guarantees manufacturers that they will be able to have the market, but also wrestles them to the ground in a way that, you know, even in US policy, we haven't agreed to do to drive those costs down. And then how much are you involved in the distribution side? Is it really like, you know, at that point, then you turn the supplies over to the governments and they are, you know, they run their countries. They should be in charge of driving it into getting to people, or are you working directly with healthcare delivery systems?
We're working directly with healthcare delivery systems. In fact, we're the largest multilateral investor in strengthening health systems in the world, alongside the disease programs, on the basic logic that if you don't have a health system with laboratories, with primary healthcare facilities, with supply chains and so on, disease surveillance, you can't make anything work. The way the Global Fund works actually is we allocate our money, and we've just raised $14 billion, and we allocate it by disease burden and the inverse of ability to play. So the poorest countries with most disease, and then we actually ask the countries, and we have a whole team of people who supports them, we ask the countries to come to us with how they want to spend it. And it's not just the procurement side of it, because one of the things we've all learned is that if you procure drugs and you haven't actually worked out what the clinical pathway is, what the treatment protocols are, and all this sort of stuff, and you don't have the trained staff, you won't actually save the lives of people. So it's very much the countries being told, you have, you know, Nigeria, for example, for the next 3 years has 900 million to spend. Nigeria comes back to us and says, we want to spend this much on prevention, this much on treatment. This is how it's going to work. We put that through actually independent scrutiny and challenge. And then we agree with them exactly what the program is going to be. So it isn't just about the commodity spend. And increasingly, actually, we're focused much more on the prevention, because you can't get rid of an epidemic simply by treating the people who get ill. You have to drive the prevention side of it hard.
The polio eradication program is just a fantastic example of how the world has divided up responsibility and attacked a problem in a singular way. And part of the story that has always fascinated me is, everybody has their role. UNICEF does the procurement and gets the vaccines cheaper, the polio vaccine cheaper and cheaper and cheaper. WHO has, for the last 48 hours ago, you can know how much polio there is in the world, where the outbreaks are, and they have the surveillance system, and then they have the convening ability to set the strategy, and they do some of the on-the-ground checking, right? Their staff will be the ones who will go down to the district level and say, are they administering this correctly? Where are the barriers, et cetera? What is the Global Fund's role? It sounds a little bit like you are the UNICEF component, but then you're also going down to the level of driving surveillance and getting to the micro level of, are they doing the HIV protocols correctly? Am I giving feedback to whether it's Nigeria, India, or Brazil about where your gaps in your system performance is? Because you're absolutely right. We find again and again and again, you can get the drugs, but adherence and following the protocols, et cetera, can be 20 to 30% performance.
Yeah, I mean, we are a partnership, and we work with WHO producing the treatment guidelines, the normative guidance, and so on. We work with UNAIDS. We work with bilateral partners such as PEPFAR on the HIV side, or Stop TB on the TB side. And what I would say was interesting about the Global Fund, well, a couple of things. One is we will do whatever it takes. In a sense, we will modify our role depending on what we think is needed to get to the outcome, which means we actually play somewhat different roles in different countries, and sort of adapt ourselves to the situation, because fundamentally our test is, are we reducing infections? Are we saving lives? Are we making progress towards eliminating these epidemics? The other thing that I think is interesting about the Global Fund, and is different from the polio example, is that the Global Fund was designed right from the beginning as a non-UN public-private partnership where civil society, including people from the communities affected, are represented all the way through our decision-making, from in the country all the way through to the board. I mean, we must be the only organization I can think of where the board member representing affected communities has the same voting power as the United States. We're very interesting from a sort of governance point of view.
Well, all of this has become thrown up into the air by the COVID pandemic, and you've written about what's at risk with COVID-19 in terms of the progress you've made against HIV and malaria and TB, but also more broadly. Can you say a little bit about the depths of your concern?
Well, very early on, with our technical partners, WHO, UNAIDS, and people did some analysis of what COVID-19 might do to the fights against HIV, TB, and malaria. And just to put it in perspective for people, HIV, TB, and malaria together kill about 2.5 million people a year. So actually, they will still be, the three of them, killing more people in total than COVID is likely to in 2020. And we looked at this and we thought, it's not implausible that you could see that number doubling. And due to interruptions in treatment, due to disruption to prevention programs, and that would be essentially reversing about a decade's worth of work, because we've essentially halved the death rate across the three diseases in the last decade. And so we said, well, that's not going to happen. We're going to find ways of making sure that simply doesn't happen. And so working with partners, we've done a whole range of different interventions, and there's been extraordinary sort of creativity in finding new ways of doing things to ensure that life-saving programs were continued to be delivered. What I think I would, reflecting on it now, sort of 6 months in sort of thing, I would say, I think we've been relatively successful in mitigating some of the near-term damage and avoiding the worst case scenarios. But where I think we will pay the real cost is in the disruption to prevention programs. And the real cost of that will come out over time, because it's just changing the trajectory of the diseases. But I don't think it's implausible that in some particularly low-income countries, the knock-on impact on HIV, TB, and malaria could actually exceed by some degree the direct impact of COVID-19.
I've seen the numbers of over 50% reduction in significant parts of the world in TB surveillance and notification programs, and it seems like HIV treatment distribution and as well as preventive programs have been heavily curtailed and redirected. I've certainly seen on the surgery side how it's disrupted surgical systems in different parts of the world where we've been working with some of the programs that we have. And I'm curious if that is turning the corner or in danger of, or likely to get much worse in the next 6 months. You know, you've been working at this. What will it take to not simply drive up not just the COVID mortality, but have dramatic increases in overall mortality?
I think it's difficult to generalize because different things are happening in different parts of the world, because the nature of the COVID pandemic, actually Africa has done rather better than people anticipated on COVID, whereas say Latin America has done significantly worse. And so you've got a very uneven pattern there. I also think the causes of disruption to treatment and prevention programs for other diseases such as HIV, TB, and malaria are evolving. So in the first wave, it was all about the lockdowns. So if there was a lockdown, somebody, particularly if they came from a stigmatized community, like men who have sex with men or people who take drugs or sex workers, found themselves unable to get treatment. Now, many of those lockdowns in many countries have been somewhat relaxed, and systems have been found to ensure that people who are on treatment do get it. But the second problem now is that as the pandemic has evolved, the pressure on health systems, the number of health workers who are either getting sick or having to isolate is increasing. And so actually you've got a different source of problems, which is mainly shortage of health workers. And I think we should anticipate that the nature of the challenge is going to evolve as we go through this. I mean, the other thing that we have seen is that many of the people that we are working with are the poorest, most vulnerable, most marginalized in society. The sheer economic impact of COVID has meant that some of those people are now without any means. I mean, we've ended up providing nutritional support to people on treatment because otherwise they weren't going to eat. And you know, there's not much point in providing treatment to people if they can't eat. So that it's as I say, difficult to generalize, and it's evolving all the time, but it's a very real impact.
Let me get down to them some brass tacks and specifics. You have been a founding partner in the ACT Accelerator, the I forget what it stands for, but it's access to coronavirus therapies or tools, because there are three kinds of tools. There are tests, there are therapies, and there are vaccines. And the COVAX facility to make sure that vaccines get out to everybody is part of that. Can you tell a little bit, because this is a major turn for your organization, it's a shift in some of the ways you're allocating resources, about the decisions to put resources now into these three areas, and maybe a little bit of a highlight of, you know, what you're accomplishing in those three areas around tests, therapies, and vaccines.
Yeah, I mean, to start with, it was a big thing for the Global Fund, which in our name is the Global Fund to fight HIV, TB, and malaria. And so along comes COVID, and it wasn't obvious to all our board members and stakeholders that we should get engaged in the fight against COVID. And my theory was that if we allowed COVID to run rampant through the communities in which we work and to overwhelm health systems, then we were going to be completely derailed in the fight against HIV, TB, and malaria. And in any case, the same people who are most vulnerable to those diseases are likely to end up being most vulnerable to COVID as well. So very early on, in February, we started working on our response, and in March, we launched our first wave of responses, and in April, we launched the second wave. And the fundamental theory was we were going to empty our pockets. So we already were spending the best part of $4 billion on HIV, TB, and malaria. We scrabbled together the best part of another $1 billion to help countries respond to COVID. That we did on our own, but then we also partnered up with many of the other agencies and organizations involved in global health to create this thing called the Access to COVID Tools Accelerator. And the fundamental idea behind this was first that we had to accelerate the development of tools. We needed new vaccines, we needed new therapeutics, we needed diagnostics that work. But we also wanted we didn't just want to do that, we wanted to make sure the notion of equitable access was there right from the start. So it was access and acceleration. The Global Fund is involved in 3 of the 4 elements of the Access to COVID Tools Accelerator. The one we're not involved in is actually the vaccines one, and that's because Gavi, the Vaccines Alliance, which shares the building with us, and we work with extremely closely, they are playing the role that we play on therapeutics and diagnostics. They play on vaccines, which is they do all the stuff around deployment and delivery in country. On diagnostics, we co-chair the partnership. On therapeutics, we chair the supply and deployment work stream. And there's also an underpinning health systems one, which we co-chair with the World Bank. But to give you an idea of sort of how this works in practice, a couple of weeks ago, the WHO approved the first 2 antigen rapid diagnostic tests, RDTs, that met their performance criteria. There have been various ones around before, but actually their specificity and sensitivity were too low to be really useful. And the first 2 products came through. The diagnostics partnership within the Access to COVID Tools Accelerator was deeply involved in the evaluation of those tests, in getting expedited approval. There was a volume guarantee the Gates Foundation did. We put up the first money for procurement, and then various partners, including us, but also FIND and WHO and so on, put together technical assistance packages so that countries could work out quickly how to use these new tests. And the idea was that low and middle income countries should be getting those tests at the same time as higher income countries, not several years later, which is, you know, if you go back into the history of antiretrovirals and TB medicines, it's the several years later scenario. And so this actually was a good test of the model of the Access to COVID Tools Accelerator of, could we actually deliver this kind of package all in one go? Because if we can do it for diagnostics, then when we get monoclonal antibodies or when we get a vaccine, we can be doing the same kind of thing with that on an even bigger scale.
I'd love to dive into a little more about like your week-to-week decision making. We had a chat in the green room, so to speak, here before we came on about, you know, choices that you have to make about where you put investments. Monoclonal antibodies are expensive. They're very difficult to administer. They're very difficult to distribute. And then there's a cheap few cent drug like dexamethasone that cuts the death rate for the for people who need oxygen because of COVID by cuts the death rate by as much as a third. What is the tell a little bit about the, you know, the decision-making process and your your role in trying to sort what should be where these investments go. It's hard to get the money from the countries. It's not enough to go around. You have a massive number of people you're trying to reach. Your life must every day be a series of moral decisions like that.
Yeah, and what has to be, particularly if you're somebody like me who isn't a clinician or scientist, you spend a lot of time asking questions because I don't know the answers. But what I am interested in is what thing is going to save most lives, reduce infections fastest. And one of the challenges we've actually had and is a kind of a bias within the system towards the kind of sexy new stuff. And the sexy new stuff is really, really important, right? I'm all for innovation and really good things, but I'm also very keen on ensuring that where we have packages of existing tools, which if you combine them effectively can save lives now, and you can do them in a small town's hospital or health facility in Zambia, then let's get on and do it. Let's not sort of stop doing that because we've got an infusion-based monoclonal that might be available late in 21, because that's not going to be very helpful. And the best example of this actually is PPE, personal protective equipment, because the starting design of the ACT accelerator didn't really think about PPE as a tool. And I said, well, it's about the most effective prophylactic we've got, right? And if we don't
distributed condoms,
make sure
you can distribute masks.
No, exactly. And and what's interesting about it is there's a whole bunch of, because it's been a backwater of the medical armory, so to speak, what you quickly discover is that nobody actually knows why the mask standards are N63 and N95. It's sort of lost in the mists of history. And things like quality assurance, things like have we optimized the sort of comfort versus, performance trade-offs and the cost. We haven't, so there's a whole bunch of stuff going on now to say, actually, can we reinvent the PPE ecosystem? Because ideally we would have these things at a third the cost, twice as wearable, twice the performance, because they're going to be part of the sort of standard kit of healthcare workers, let alone communities, going forward. And the other critical element here is places like Africa have a much lower ratio of healthcare workers to the population than, say, the United States. If we lose those healthcare workers between now and when we get a vaccine, we won't have anybody to distribute the vaccine anyway. So it's absolutely critical to be ensuring that they get, that we treat PPE as tools and we get it there. But I mean, these are difficult discussions to have, and the trade-offs, I mean, the most difficult trade-offs have been around things where we have very scarce resources and we have needs. I mean, for example, early on in the crisis, we were negotiating with manufacturers of automated molecular diagnostic tools. So people like Abbott and Roche and Cepheid and so on, and basically buying up as much as we could for low and middle income countries. But as much as we could was a tiny fraction of what those low and middle income. So we had to devise an allocation model. And you can imagine the tensions around devising an allocation model like that. And there is no right answer when your total available supply is like, single-digit % of what it should be, then trying to cut it up perfectly is not a possible task.
Well, I'm imagining then your description of your role is really you are constantly having to make allocation decisions with scarce resources. You're spend a lot of your time trying to capture more of those resources, but then a ton of your time is trying to ask questions so that you are understanding and pushing on how that allocation can be have the best possible outcome along the way. One of the chronic things that I say, I think a lot about systems and how we build around those systems. And in order to deliver HIV care, TB care, AIDS care, we saw during Ebola that it goes through the same system, which is primary care. And similarly here, COVID care has a linchpin of, does a primary care clinic have the capacity to handle people coming in? Do they have the PPE? Do they have a pulse oximeter to measure the oxygen level? Some very basic things that you can distribute and make available. And those primary care systems are some of the least funded aspects. So often public health dollars go to these verticalized programs instead of the primary care systems that are with people across the course of their life and help them live those longer, healthy lives. How do you square that neglect of the system that you need for the distribution? And we run into it again and again and again now with COVID.
Yeah, I mean, one of the things when I came into the global health world, I found really quite strange was the almost kind of religious fervor with which people either espoused a vertical approach or a horizontal approach and sort of argued about the relative merits of the two. And it's, the way we think about this is you kind of got to do both. You got to build a system, because if you don't have a system, nothing functions. But on the other hand, if you have a primary healthcare facility and you haven't actually bought the antiretrovirals, then you can't treat patients who are HIV positive. You need the vertical expenditure and the horizontal. And the one challenge that I think purely kind of systems type approaches have often had is they tend to measure success in terms of input variables. And one of the strengths of a more sort of disease focused or community focused approach is you can use lives and metrics of well-being as your ultimate indicator of impact. And so I think actually COVID is going to force us to get even more system oriented. But I want to make sure that as we do so, we keep that laser sharp focus on what is the difference we're making to people's lives, as opposed to metrics about sort of how many health workers there are or how many clinics have a pulsometer or whatever, because ultimately that's what really keeps us focused and honest. But you're right. I mean, COVID is a really good example. In many countries, the fundamental infrastructure and capabilities that have been used to do the COVID response have been those that have been put in place for HIV, TB, and malaria. I mean, if you think about the diagnostics, fundamentally, this has been run on instruments that were put there for viral load testing or TB diagnosis. And the same lab technicians, all that. And so I do think we need that sort of systemic focus, but we need to keep it very outcome oriented.
Well, this is a wonderful moment because I get to make a pitch, which is I'm a co-founder with Bill Gates for the Gates Foundation, the World Bank, and WHO of a group called the Primary Healthcare Performance Initiative, where we have been getting beyond input measures on the primary care system to actually looking at management, diagnostic accuracy, customer care, and then not just the allocation of dollars and how many doctors you have out there, but where are the gaps in the system performance, and doing it at a national and subnational level now for 25 plus countries. And UN has just joined as a member of the steering committee. We would invite you at the Global Fund to participate as well, because this does completely dovetail and it's going to be essential. So I get to make that pitch. The 4 minutes left, I want to, before I turn it open to questions, I'd love to take a moment to step back a little bit in your career. You had the world of banking, and I don't know what happened when a banker became the head of the Public Health Global Fund and a public health doctor like Jim Kim became the head of the World Bank at the same time or thereabouts. But you've gotten to see two worlds. And What works better and what is worse as you look at your job now in the nonprofit sector versus the for-profit sector for people who are navigating both of these pathways to making impact?
Well, let me start by talking a bit about how I ended up doing these two very different things, because actually the Kennedy School played a big role in this, in that when I had done 9 years as the CEO of Standard Chartered, including navigating through the global financial crisis, I think I was the sort of longest tenured CEO of a major bank in Europe by the time I stepped down. I really didn't want to do the same kind of thing again. And it was Larry Summers actually who said to me, why don't you come and park yourself back at the Kennedy School? And then I had done a MPA2 many years ago, and I thought that seemed like a good idea. I did some work on technical aspects of financial issues while I was at the Kennedy School, but I actually focused a good deal of attention on the economics and finance of global health, because I was intrigued by health and I thought this was kind of an interesting area. And I ended up doing some work for the National Academy of Medicine and the World Bank and so on, ironically, on the issue of pandemic preparedness. And why was it that the world didn't seem to get its act together about this? Now, while I was doing that, this opportunity came up. I ignored it. Then I threw my hat in the ring, and then I took my hat out, and it was all a bit of a complicated story. But I ended up doing it. And as you say, Jim Kim and I used to laugh about the fact that we were kind of in each other's roles. And what would I say are some of the sort of advantages and disadvantages? Well, one of the things I would say is that in the world of finance, certainly, one gets much more explicit about trade-offs. And it's quite difficult in the world of global health. And I completely understand, because in the global health world, trade-offs are often about people's lives. Do I save more if I do it this way, or do I save more if I do it this way? But they're often different people. And people are very uncomfortable, and understandably, and they should be uncomfortable about making those trade-offs. But what it sometimes means is you end up with a kind of fudge decision, which means you kind of do a bit of both. And that's, so I think that's one issue I see.
Maximizing lives versus maximizing profits is just harder metrics to have as a clear standard.
It's really, it should be hard. But on the other hand, what it sometimes means is you sub-optimize the decision-making. I think the other thing that I find, and I still can't quite get my head around, is the comfort with having data that is a year old. To give you a good example, this year, 2020, COVID and TB will probably be roughly neck and neck in how many people they kill in the world. So TB will kill about 1.5 million people, and on current rates, COVID will be around 1.5 million people. Now, the interesting issue is that on COVID, on January the 1st, we will know to maybe 90% accuracy how many people have died in 2020 of COVID. To get that same number for TB, we'll have to wait till October.
Right.
I mean, and I just don't,
you can't make decisions easily that way.
You can't make decisions on that basis. And particularly when you take a disease like malaria, where the month-to-month volatility of malaria might be 30–40%. The idea that you're looking at last year's data as a basis for making decisions is just bizarre.
You've got a car where you can tell how fast you're going 10 months ago. That's great.
Yeah. No.
Let me open it up to questions, and thank you for that dive into it. We've got a Harvard college student named Blake who's got a question. Blake, if you can go ahead.
Hi, thank you all so much for coming. My question is related to a vaccine for COVID. In America, it seems like some of President Trump's comments about rushing a vaccine through and some of his comments delegitimizing COVID have made people on both sides of the political spectrum skeptical to a vaccine and concerned about its safety. So how how will governments and organizations ensure that A, people believe a vaccine is safe and are willing to take it, and that B, that the vaccine is safe?
Peter.
Very good question. And I think it's very important that we don't take shortcuts. Everybody wants a vaccine, right? But if we take shortcuts and we end up with a vaccine that actually does have damaging side effects, then that will have a massive knock-on impact in terms of people's willingness to accept another vaccine, or indeed vaccines for diseases other than COVID, because you undermine confidence in vaccines more generally. Certainly the vaccine approach within COVAX is very much one of saying we've got to get it right. You know, we want to move faster than ever before, but we also want to ensure that all the regulatory and clinical trial protocols are taken extremely seriously, so that people have confidence that when they are told that this is a vaccine and you should take it and it'll protect you, that they're safe in doing so.
I think just to echo that the US process, I think again and again, and we see that in countries that have pulled together to fight the fire across partisan lines, they have been successful, whether it's convincing people to wear masks, to get tests, and now to you know, believe or not believe whether that vaccine is going to be safe. We're heavily divided in the United States. I think it makes a huge difference. The FDA is now asserting its independence quite firmly, even at risk that this, you know, the Secretary of Health and Human Services has all been made clear he will fire the FDA chief, you know, after the election, especially if Trump wins, and perhaps even if he doesn't. So, you know, a remarkable op-ed in today's USA Today from Peter Marks, who oversees the vaccine procurement process and the vaccine approval process at the FDA, spelling out exactly how they will be providing clear standards, applying clear standards to the approval process. And I think those are going to be important ways, because at that point you'll see leaders, whether it's medical community leaders, religious leaders, coming in behind a sound vaccine, and that's going to be a critical part of this as we go on. Thank you for that question, Blake. Let me go to Shabnam, a woman in global health who is a lead fellow, I guess. So Shabnam. Were you able to get Shabnam on? If not, we can hang on and see whether she can be poked on. Peter, what do you see? You know, one unwritten discussion here is the way that the US has withdrawn from the global stage on fighting the pandemic. The US is normally a place that would be providing tremendous leadership, like we saw in Ebola. What has been the loss that you've noticed, and how is it harming your efforts at a global level?
There's no doubt that if you're fighting a global crisis of this magnitude, having particularly the sort of G7 and G20 countries, and the US is the largest and most powerful of them, united behind a common agenda, makes it a hell of a lot easier. And we haven't had that in this situation. What we have had, however, is a lot of scientific and technical cooperation. So in leading the diagnostics partnership of the ACT Accelerator, I've been talking to the people in RADx, for example, in the US, and I know that the vaccines partnership talks with the Warp Speed people. I think the biggest thing, though, is that the messaging to the world has been more fragmented than we need. And also, frankly, the resource mobilization, because the reality is that the richest countries in the world have actually spent trillions of dollars in their responses to COVID, but most of that has been on mitigating the socioeconomic domestic consequences. Actually, the incremental spend on tools to fight COVID has been in the tens of billions versus trillions. And overseas assistance helping the poorer countries in the world respond to this crisis is flat. And so I think, and it's in a sense, when you've got fragmented global leadership, it's harder to address that big issue, which is there is money around, we're not spending it really on the right things right now.
Got it. Nicely diplomatic. I think we've lost Shubnam, so next question comes from Carson from Harvard College.
Hi, thank you so much for this discussion. It's been really fascinating. I'm wondering a little bit about the reliability of the data that's used to evaluate public health challenges in developing countries. Like I remember earlier in the course of this pandemic, the president of Burundi was asked how COVID numbers in his country are staying so low. And he responded something to the effect of, oh, that's easy, we just don't have any tests. So I'm wondering, what role does the reliability of public health data play in deciding how to allocate aid between one country and another when there's not really reliable data to compare those two countries? Like, does that metric fit into the allocation model that you were talking about earlier?
Excellent. Peter.
Well, it's a very good question, because early on in the discussions about how to allocate molecular diagnostics between countries, this question of should we do it on cases or other metrics, and I said no way we do it on cases. We do it on population. But we start with population, because otherwise what you're doing is you're taking the countries who have no tests and condemning them eternally to having no tests, because their numbers of cases are going to be incredibly small. And so the data issues are enormously important, and we need to be always questioning whether the data we have actually reveals what is actually going on, or whether it's a proxy with a significant risk in it. In many cases, it is that.
So if you're a Vietnam with a very low rate of infections, you still have the same allocation that a Latin American country would have for testing and therapeutics capacity under that kind of formulation. Is there pushback at all around taking that approach?
Huge pushback, and actually we don't do it quite as simply as that. What we did was we did population, and then we put two further factors in it. One was incidence, so what kind of burden of COVID do you have? And the second thing was a measure of health system weakness, on the basis that the weaker your health system, the more that infections are likely to translate into mortality. And so we built in those. But as an example of the difficult kind of moral trade-offs, is there were intense debates about whether we had got those metrics right. And in fact, the right answer was that none of them were right, because the quantum we were trying to allocate was so out of kilter with the need that, trying to fine tune it wasn't really the right thing to be spending time doing.
Fair enough. And so Carson's point about the measurement of COVID fits there a little bit. One of the ways that we've gotten around that is by looking at the positivity rate as well. North Dakota, as of yesterday, has a 43% positivity rate, which indicates that they're massively undercounted. They're just not nearly enough tests to pick up on the massive volume of infection spreading there. And that probably is a global story in much the same way. We have next Estella from Harvard College. Estella, if you could join us.
Hi. I'm originally from São Paulo, Brazil, and the pandemic has ravaged through urban communities specifically. I'm in favelas. And my questions to the discussion that we were having earlier with the role of the United States and more developed countries in helping lead the global fight against the pandemic. My question pertains to the distribution of the vaccine, similar to what Carson was talking about, and whether you foresee a change in the position of the United States and Western Europe on the global stage once the vaccine comes out, and in helping other countries, other less economically developed countries, fight against the pandemic in the later stages over the next few months, or whether it will remain unchanged and the burden will rest with international organizations.
Peter, what do you make of that? I mean, one of the interesting things is that you do have, in this case, Republicans, Democrats strongly behind getting a sound vaccine out there.
Yeah, what you haven't yet got is the US participating in COVAX. And COVAX is this vehicle under the ACT Accelerator, which is designed to actually ensure that we don't just accelerate the tools, but we ensure equitable access. And we currently have, I think, 184 countries. It's a vast number of countries. In the well over 150 countries are involved now in COVAX. And you can either come into COVAX as a country that is self-financing, and essentially what you're doing is buying access to a pool of candidates. COVAX now has relationships with 9 different deals with 9 different vaccine candidates. Or you can come in through the AMC vehicle, which is essentially for countries that will pay a small share of the costs, but essentially be supported in getting access. And the European Union has actually been a key driver behind supporting the development of COVAX. Now, I think this is a huge achievement just to get this off the ground, right? And have that many countries signing up to participate. Ultimately, you want this to be a global thing. We're not quite there yet, but more countries are signing up every week. The one thing I would say, though, is when it is really important that we don't get obsessed with the notion of a vaccine as a silver bullet. It's quite likely that the first generation of vaccines are only going to be partially effective. And therefore, we also need to be accelerating the development of therapeutics, and diagnostics play a critical role, whichever scenario you have about the efficacy of vaccines and therapeutics. And the same issues of equitable allocation are going to be just as acute with the next generation of therapeutics and diagnostics as they are with vaccines.
Yeah, Peter, you've outlined it. I read a piece you did that outlined a nightmare scenario where you have a combination of measures really deployed in the Western world, allocated through their ability to borrow, go take on debt at large amounts, and essentially eradicate from our borders the worst of the epidemic. But that in low and middle income countries, there simply goes a wall up that bans travel and doesn't offer help to those sectors. We can easily imagine that in a world of where everybody starts to pull up walls and it becomes America first writ large. Briefly on that, and then we'll go to, I'm just curious your take on how we avoid that, whether in danger of it, and then we'll go to the last question.
Well, I think the trouble is it's not a theoretical scenario, because the reality is what we did with HIV and tuberculosis is really that scenario, which is that when they were big killers of people in rich countries, there was a huge focus and mobilization of resource against them. And they were pandemics, both were pandemics. But when they stopped killing people in rich countries, they became very much more a sort of humanitarian global solidarity issue. And the scale of money, while still fairly substantial, wasn't enough to really get rid of them in the same way. I mean, again, the contrast between TB and COVID is really interesting. So they'll kill roughly the same number of people this year. The total global amount being spent on TB prevention and treatment in the world today is about $6.5 billion. Now, the number for COVID is not 100 times more, right? It's several hundred times more. And yet these diseases are killing roughly the same number of people. So what I'm, the nightmare scenario for me is I end up with 4 diseases instead of 3 diseases, right? That I have another, what you might call a residual pandemic to deal with 2 years from now. The positive scenario is that COVID gets people to think differently about these things and says, actually, not only do we want to get rid of COVID everywhere, but why are we still having TB killing 1.5 billion people when this is a disease we know how to treat and people don't need to die of? And likewise, why can't we get on top of HIV in the way that we have in most rich societies in the world?
All right. Professor Sikkink, thank you for joining from Kennedy School. We'll give you the next question.
Yeah.
And maybe the last, we'll see how it goes.
Thank you. So I'm teaching a global governance class here at the Kennedy School this semester. I've encouraged my students to be attending here. And in that class, the second day, we look at a Harvard Kennedy School case on the malaria campaign, in which the Global Fund plays a really important role. And we see it as a global governance success story. And then the third day of class, we looked at COVID, and the students were asked to grapple with the huge challenges that this poses for global governance. So given that they've been thinking about it and some of them are here, I wonder if you'd share your ideas about the best explanations for why COVID has been so difficult when the Global Fund and the world community indeed was able to grapple so successfully with malaria.
Well, we haven't got rid of malaria yet. So, you know, my metric of success is when it stops killing hundreds of thousands of children. But you're right. I mean, malaria actually is a global health success story in the sense that the mortality for malaria has come down very significantly. And part of that reason is because the world adopted a global approach. Nearly 70% of international funding for malaria goes through the Global Fund. And so a lot of the governance challenges around malaria are actually around the way the Global Fund fights malaria, because we are the big player. I think the problem with COVID is, well, one, we didn't know what we were dealing with, right? And every pathogen has its own characteristics and dynamics, and we're still discovering with COVID quite how this thing is unfolding. And two, whereas malaria was, in a sense, for the rich countries, somebody else's problem, but one they wanted to help deal with, this is a problem that is on the doorstep of the rich countries in the world. And so actually, if you're the Prime Minister of the UK or Chancellor Merkel or the President of the US, when you think of malaria, you're thinking of a problem somewhere else. When you're thinking of COVID, your biggest concern is what is it doing to people in your own country, to your political position and credibility in your own country. And I think in some ways that has made it much more difficult to get mobilization of, say, the G7, the G20 around this, because actually they're all looking inward, and getting them to look outward and look across the border stage and say, these are problems we need to deal with collectively, has been a big challenge. And in a way, I think global institutions like mine have had to be quite kind of assertive in making the point that you're not going to deal with this just as a sum of individual nations. You need these collaborative mechanisms, I mean, ultimately we need to get to the levels of coordination and collaboration that we've got with a disease like malaria. And I think the ACTA mechanism is quite remarkable. I mean, when you think that this thing didn't exist in mid-April, and yet most people, I would say, in global health would say you're seeing an intensity of collaboration and real results being driven out of it that people haven't seen before.
Mm-hmm. Thank you.
Peter Sands, thank you for this conversation. Thank you also just for the work you're doing. You're relentlessly attacking the biggest killers in the world, and greatly appreciate the sophistication of marrying the horizontal and the vertical that you're attempting to do. Keep up the great work, and we know the rest of us will keep on trying to find ways to make it easier to do that. And thank you for taking the time with us at the Kennedy School.
Well, thank you, Atul, and it's a privilege to have somebody of your caliber, whose books I've loved, moderating a discussion like this. It's fantastic. Thank you.
Thank you. And thank you to everybody who's joined in. Have a great day.
Thank you.